Okay, started. You can do it.
Good afternoon, everyone, and welcome to the 7th episode of our Medical Education Clinical Reasoning program. We're pleased to meet you all again, and we hope that you're enjoying this series. Let us start this episode by introducing our panelists, as usual. Our clinical advisor is Dr. Ali. Today's resident is Dr. Sara Al-Qasimi, and of course, our two case discussants, Maryam Al-Falasi and Khalid Ahmed. We'll use this time to allow our speakers to briefly introduce themselves. We can start with you, Dr. Ali, please.
Assalamu alaikum. Ali Al-Shidi, internist from Tuam Hospital.
Dr. Sara.
Hi everyone, good afternoon. My name is Sara Al-Qasimi and I'm currently an R1 internal medicine resident at Cleveland Clinic, Abu Dhabi.
Hey guys, Khalid Mahmoud here and I'm a fifth year medical student.
Good afternoon, I'm Maryam Al-Falasi. I'm a fifth year medical student.
Thank you all for this introduction. Again, we would like to remind our audience to leave their comments and questions in the chat box for us to address them later on. With that, let's leave the floor to Dr. Sara Al-Qasimi as she walks us through today's case. Dr. Sara, the floor is yours.
All right, thank you, Selma. The case that we are going to be discussing today is the case of diarrhea. And the chief complaint that I'm going to present with is a 42-year-old female presenting to the ER with a 3-week history of diarrhea. So Khalid or Maryam, whoever wants to start, how do you approach this chief complaint?
All right, so it's 3 weeks, so it's persistent diarrhea, right? So it's between acute and chronic. So I'd like to first start and question her exactly on what she considers as diarrhea and how what happened before those 3 weeks. So has there any change in her food like intake? Has she traveled anywhere recently? Has she undergone any procedure 3 weeks ago? Let's start with the history first.
Okay, and just before I present the HPI to you, I just want to know what you're thinking behind those questions. So let us know what's going on with your head with those questions. What are you ruling in? What are you ruling out?
With the change in food intake, she could be having like a persistent infection, but I think it's still like too long for 3 weeks now. What I meant by past medical history, like she could have had antibiotic use, procedure history. She could have done a gastric bypass, which can cause like dumping syndrome. So just a few things that I'm thinking about. Could be completely random, but they just came to mind.
Okay, that's great. I think that's an excellent start. Maryam, do you have any other questions before I present the rest of the HPI?
Yes, one thing Khalid mentioned that what she considers as diarrhea, just to make sure, for example, is it watery? Is there any blood, like the consistency and all of that?
Okay, that sounds good. All right, so she presents to you with a 3-week history of diarrhea. She describes it initially as a diarrhea that started mildly with 3-4 stuffed stools a day, but that has increased in frequency to 4 to 7 times a day. It's watery inconsistency. It's associated with generalized cramping abdominal pain that gets worse after eating or with a bowel movement. Her normal bowel movements are usually just once or twice a day. She also endorses tenesmus and urgency. She denies fever, chills, rigors, loss of consciousness, nausea, vomiting, diaphoresis. She doesn't notice any blood in her rectum or any dark stools. For recent history, she had a sinus infection a few weeks ago, for which she completed a 7-day course of amoxicillin. She has no sick contacts, no recent travels. She doesn't take other medications, and she hasn't ordered out or eaten anything out of her usual meals. Is there anything else that you would like to ask with the HPI?
You mentioned that the pain increases after stool movement.
Yeah, it gets worse after eating or with a bowel movement.
We're still on history, right? We're not moving on to physical.
Probably, Doctor, probably Khalid, your question, is the pain related to defecation? Like, does it become better after defecation, or it's only with the defecation? Isn't it?
Yes, doctor.
Yeah. So, Sarah, can we elaborate more on that?
So it doesn't only occur with a bowel movement. It also happens when she eats. But she noticed in those two scenarios.
Mm-hmm. So, sure. Okay. Probably can carry on then.
Okay, I would like to ask her if she had any weight loss or any noticeable weight loss recently.
Good.
No weight loss recently.
And no travel history?
No travel history.
And she was compliant with the amoxicillin for 7 days?
Yes, she completed all 7 days of it. Okay, shall I move on to the review of systems? If there are any...
One last question. Is she on any other medication?
No,
like
she doesn't take, she does not take laxatives, no. All right. Okay. Mariam, any other questions from your side?
Not really.
Okay. So on review of systems, she denies any chest pain, cough, shortness of breath, burning micturition, dysuria, increase in frequency or urinary urgencies, no arthralgias, no conjunctivitis. For her past medical history, she has asthma that's well controlled, and she's a thalassemia carrier. Medications, she doesn't take any. She has no known allergies. Surgical history, cesarean section twice. Family history, asthma and hypertension in her mother, diabetes, hypertension, and ischemic heart disease in her father. I'll just give the scribe a few minutes to type.
So while you're doing that, Sarah, probably I can highlight that probably there are lots of questions. I'm sure still probably you can ask in the history. So how we can improve that? Probably you can just go and do some differential diagnosis in your mind before we come to physical exam. So what I do personally when I encounter such entities, try to get differential diagnosis at the presenting complaint, at the history of presenting complaint, and after each category of your history taking, and then again you will make differential diagnosis when you do the physical exam. Subsequently, you will not need to revisit the history taking after the exam or after investigation. So I guess that's my advice that can help you getting to the history taking as much as you can. I'm not sure, Sarah, if you will discuss this later, but good question from Khalid initially when he asked, was it really diarrhea? That's a very important question, and I'm sure you will elaborate on it probably later. And also, as a clinician now for more than 10 years, presenting with diarrhea in somebody who had been on laxatives, it's an issue also. So that was a really good question. Always ask if the patient on any sort of laxatives. Sometimes they don't know that's cause diarrhea also.
Okay, thank you for your suggestions, doctor. I was going to ask the differentials after the history, then after the
Sure.
history. It's almost at that point. We'll just go through the last portion of the history, which is a social history. This patient works as a nurse at a tertiary hospital. She's married with 2 children, non-smoker, does not take alcohol, and she doesn't have hobbies that include recreational camping or water sports. So at this point of the case, what differentials that are on your mind at the moment?
First of all, we could think about infectious sources, including, for example, C. diff, Clostridium difficile, any enterotoxigenic bacteria.
I'm also thinking about other like more invasive as well, because you don't know where she ate. We need to get a detailed history on that. So she could have like a salmonella infection, or like for example the enterohemorrhagic E. coli from uncooked meat. So I think we should go back and look at that in the history. Moreover, there are some, like, for example, herbal medications that some people take, like Gila, and they can cause diarrhea from what I know.
Okay, those are all excellent differentials to start with. I'm sorry, Mariam, you were...
Can I also add? Yeah, can I add more differentials?
Yeah, sure, of course.
So we should also think about like irritable bowel syndrome and ulcerative colitis and Crohn's, and any sources of malabsorption, for example, like any, for example, pancreatic insufficiency and the sort.
Yeah, I forgot to mention IBS. I was actually thinking about it, so I would ask her if she has any recent stressful event, or inquire more about her mental health recently as well.
Okay, that's excellent. I like how both of you are thinking outside of the infectious causes, because I know diarrhea is something that is always tied to infection because it's usually the most common cause. But I'm glad that you're thinking outside of that and broadening your differentials. So when we do think about diarrhea, the both of you have started well. At the beginning of the history, Khalid had asked about the time course. You had classified it initially as a subacute course because it's been 3 weeks. Since acute is less than 14, subacute is 14 to 30, and chronic being more than 30 days. So you correctly identified that this was a subacute diarrhea, and this helps narrow down your differential. And then when I asked for more differentials from the both of you this time, you started with buckets of infection or secretory, dysmotility, osmotic. All of you touched upon different diagnoses from those 4 buckets. So right now, what are your 4 or 5 top differentials from both of you that we're going to carry on to the physical examination that you'd like?
C. diff.
Okay.
Because of the antibiotic use.
Okay.
And they said there's no bleeding, there's no, so like I think that would rule out the ulcerative colitis and the other inflammatory like Crohn's. Could be IBS.
All right. Any other differentials?
We could also think about like lactase deficiency.
Okay.
It's usually watery diarrhea and non-bloody.
Sure.
Yeah, we can also have celiac disease in there.
We have what?
These are the celiac
didn't-
disease.
Oh, okay.
So I think we could group it with lactase, right? Since they're both osmotic types of diarrhea.
Good. So Mariam started classifying actually when she started asking about infection, if you would allow me, Sarah. So that's very good start. Again, after you start to gather the history, probably the easy way to get to differential diagnosis, always for any sort of disease, try to categorize the etiology. So Mariam started with the infectious disease, and then she mentioned the irritable bowel syndrome. Then you guys start talking about malabsorption, such as pancreatic failure and celiac disease. So I think if you do it that way and start to classify the etiology before you mentioning the definitive disease, that would make life easier for you and faster. So if you go back again, what could be the 3 or 4 categories as etiology for diarrhea? Or probably Sarah can help with that.
So when we do classify diarrhea, we usually classify them by both their time course and their mechanism of action.
Good.
We've already discussed the time course. So moving on to the mechanism of action, there are usually 4 mechanisms that we think about. One is inflammatory, osmotic, secretory, and dysmotility.
Yeah.
And this is the kind of framework that we're going to use for a case like diarrhea. So if we take inflammatory, that can also be expanded to infectious and non-infectious. And then we can also expand on the infectious category by making it non-invasive and invasive. So always try to organize your thinking when it comes to differentials. It helps a lot with your management later on. What are you looking for on physical and how to treat the patient in the end? So we're going to start with that for now. I will talk more about the different categories later on, but for now, let's go through the physical exam. So for vitals, her temperature was 36.6 degrees, heart rate of 76, BP of 119/76, respiratory rate of 19, and SpO2 of 98% on room air. So when you have a patient with diarrhea, what are the things that you look for in the vitals, first of all?
I'm looking at her temperature. Is she febrile? And her blood pressure. How severely is she dehydrated?
Perfect. That's how you should always approach someone who comes in with diarrhea. You start any exam with vital signs and how the patient looks like. So on vitals, they can reveal hypotension, fever, orthostasis, tachycardia, bradycardia, tachypnea, and then the patient's general appearance. If you have a patient who has been having diarrhea for a long time or a lot of episodes of diarrhea, they would usually come in appearing ill, looking very lethargic. And again, it depends on the severity of diarrhea, but you need to see the patient. How do they look like initially? Are they sick or not sick? Is this something that needs acute management or it doesn't? Or it's something that can wait and you can continue on with the physical exam. So what do you think about this patient's vitals? Is she someone who is potentially very sick and needs management right now?
Well, she looks vitally stable right now.
Yeah, she does. So let's continue on to the physical exam. Generally, she looks well appearing, and no acute distress. She was comfortable on the bed. So this is someone that we can wait on and continue on exam. What are the other things that you look for in a physical examination of a patient who comes in with diarrhea?
I'm trying to see if she's pale. Does she have any signs of anemia? So I'd like check the conjunctiva. Continue with fluid assessment, like her capillary refill and skin turgor.
Okay.
What else? I'm trying to remember. Her pulses maybe, but I think that's in like severe cases. She looks,
It's still something you should check for.
And her mouth, like her oral cavity, is it dry? Is it?
Okay, I think that's a good start. So for the first category, no jaundice, no pallor. She does have dry oral mucosa though. Her skin is a little bit dry, and skin turgor was normal. Her cardiac examination, regular rate and rhythm, normal S1, S2, no murmurs, no added sounds, no edema. On respiratory exam, clear to auscultation bilaterally, no wheezes, no crackles. Now, in a case of diarrhea, of course, GI exam is probably the most relevant one. So is there anything specific that you would like to check on abdominal examination or GI examination in general?
Go ahead, Maria.
Yeah, I would look if it's I mean, it's already mentioned in the history of presenting illness that's diffuse, but I would check that, and if there's any like rebound tenderness and all of that.
Okay. So for her GI exam, it was soft with generalized tenderness on palpation. There was no specific area. Her bowel sounds were hyperactive. No distension or organomegaly was noted. No guarding, no rebound. Neurological exam was normal. She's alert oriented. No grossly focal neurological deficits were noted. Okay, so at this point of the case, does the physical exam help you exclude or include more differentials from the list that you guys have already thought of? Or is your differential just staying the same for now?
Can, like, the fact that she's afebrile kind of rule out the invasive infections? Like, not completely, but like start to rule out.
Okay, invasive infections like what?
Like salmonella or an DHEC, or for example, you said that she didn't go camping, so that
No.
could rule out like Giardia, the freshwater pathogen.
Okay. So you think at this point it's an infectious process, but a non-invasive one, correct?
And I think we still need to look more at like the stool or white blood cells and all, but I'm saying that it could start of like straying away from that direction.
Okay. So what is your top 2 or top 3 differentials so far?
I think I need to know more before I decide that.
Okay, fair enough. Maryam, any changes to your differentials or to the list that we have?
Not really, not yet.
All right. So if we move on to investigations, now that you have a list of differentials, how would you like to work this patient up? What would you like to order?
First of all, I would start with CBC and electrolytes.
Okay, and what are you looking for with those things?
So first, I see her, for example, white blood cell count, and her electrolytes, if there is any imbalances that we should address, especially she's been having a subacute diarrhea. And then for localizing the pain, I would need to do stool studies, like stool culture.
Okay, that's a good start. Khalid, do you have any additions to that?
Yeah, I would do a stool, white blood cell, red blood cell, to see, like maybe she might have like microscopic bleeding, or I want to see if there's white blood cells in the stool that could like lead us towards invasive infections. Perhaps also do osmotic gap, like it will help to distinguish if it's osmotic or secretory, like in those terms.
Okay, I think that's a fair enough list of investigations. So she had a CBC done. She had a white blood cell count of 7, which was normal, with no left shift. Hemoglobin of 99, MCV of 64, MCH of 19. So she had a picture of iron deficiency anemia, but the rest of her CBC and differentials were normal. Her U&E was completely normal. She had a CRP done, which was slightly elevated at 26. She had a stool culture done as well, which was negative.
Oh, we forgot the C. diff nucleic assay.
Exactly.
Yes.
So,
okay.
so if I could comment, Sarah.
Yeah, sure.
So you guys, you bought a differential diagnosis. So when you come for a workup, the utility should be as at its best level. So now you put a C. diff as differential diagnosis, isn't it? Top in the list. So why not to go and hit that possibility? Why you don't go to the money, you know? So probably you should have mentioned C. diff workup either in terms of toxins or culture, because that will be in line with your differential diagnosis. You definitely need to do your electrolyte to make sure patient is not very dehydrated and renal impairment or electrolyte imbalance. But if you mentioned it once, it would be better that you need to study the stool for C. diff also.
Yeah. Always remember your differentials is what guides you later on what to investigate. So based on what you have, that's what you order. That's what helps you. So she also had a Clostridium difficile toxin A and B test done, and that was positive.
So probably for most of the diarrhea disease, they self-limiting. This lady coming with 3 weeks diarrhea, and as you can see, even her exam, she's totally fine. If you show me the numbers only without telling me the story, the vital signs and your general exam, probably I would not think doing any investigation, isn't it? Because this lady has history of loose stool, frequency, whatever, but at the same time, she doesn't look sick on clinical exam.
Yeah.
So this is the time when you come and try to limit your workup and your investigation, and try to get as low as much from the list of investigation.
So can we safely say at this point that it is in 100% C. diff?
Yeah. C. diff toxin positive with this history is almost 99% this is C. diff related diarrhea. Now, you know the Clostridium difficile is a bug which may exist in our colons, but the toxin should not be at the level where it can be detected in the stool. So keeping in mind the history of antibiotic use for 7 days and worsening symptoms, and then she's having positive toxin. Yeah, this is Clostridium difficile related diarrhea. Now, probably Sarah will discuss later that the C. diff colitis or diarrhea, there is a spectrum of symptoms and severity. So sometimes may not be bad like this one, but at some stages it could be really serious and move to the very sick patient. Now, Khalid, you said something that when Sarah mentioned the investigation and the examination, you were right saying patient doesn't have fever and looks vitally stable, and probably we should think back and put the infectious etiology lower on the list rather than the top in the list. But you know what? It's always the history taking probably has the bulk of differential diagnosis, and the money is there. So if you tell me a patient coming with diarrhea after she received 7 days of antibiotics for sinusitis, probably that would be the heaviest part in your assessment. Probably the money will be there because sometimes they don't necessarily to be sick to the point you think they have bad colitis.
Thank you, doctor. I wanted only to rule out the invasive, like not the entire idea of infections.
Yeah. Okay. So as Sarah said, basically you don't need to exclude totally. You are right. It still could be other infection like salmonella or whatever. But why we why we put differential diagnosis in order? The implication is how much you do for them and what do you start with. So if you put C. diff in the top, for example, in this case, if you go and check the toxins for C. diff in the stool, you will not need to do lots of investigation. So you keep your utility at its higher level. Now, if the opposite, if the case is not going this way, you may start investigating something else without doing even Clostridium difficile. So, you know, the differential diagnosis for diarrhea is very vast, like really big list. Why you guys choose to do Clostridium difficile here after CBC and urea electrolyte without doing much other investigation? Again, because of the history taking. But otherwise, you already started talking about even mental health. So you're talking about something probably far away from this, like functional diarrhea or irritable bowel syndrome or something else. So we really need to put the differential diagnosis in order as per our history taking and physical examination. So we go to specific investigation that give us faster answers.
Okay. Any other additions from Khalid or Mariam about Mark?
If you don't have question, Mariam and Khalid, can I suggest now before probably proceeding forward with the topic of Clostridium difficile, always for any disease, myself, like personally, I start with the red flags. So for any presentation, so in this case, do you have an idea what are the red flags with diarrhea? What you should make sure you ask the patient or examine in this lady?
Is it high fever and then severe pain, like that does not improve with defecation? And
Good.
then if she is immunocompromised,
Yes.
and another one which she has positive, which is the antibiotic use,
Mhm.
and long duration, and lastly, if she was previously hospitalized or no.
This is, you mean this is the risk for getting a Clostridium difficile infection? You are right. Yeah. But my question was, Khalid, in general, what will put diarrhea as a serious one? I mean, what red flag history you would like to obtain in general?
Touched upon this. You asked for some of these during the HPI actually.
Yeah, probably you ask
Yeah.
about.
You mean like the travel and
Yeah. So if you go back to differential diagnosis, there could be some entities causing diarrhea, but are not serious disease. But what serious disease you think could be there causing diarrhea? And you need to ask specific question to make sure you don't miss it or you don't take long time to figure out. Can cancer cause diarrhea?
Yes.
Yeah.
Councillor syndrome?
So we can explore.
Yeah.
Yes, exactly. So we could expand more on the weight loss and the night sweats and the
Yeah.
flushing.
True.
All those.
Yeah. So you know what? Sometimes we do fixate on a short list of differential diagnosis because of something in the history, like for example, use of antibiotic. So before coming to the investigation and knowing this is C. diff infection, you probably would fixate a little bit on that direction of diagnosis. So the red flags question always save your practice, like you don't miss major things. So I know she's middle-aged, but she's cancer, either familial or whatever cancer that can cause diarrhea, especially she's coming with 3 weeks of diarrhea, non-resolving one, but worsening one. Okay, Sarah, probably you can carry on.
So just before we talk about the C. diff infections, I just wanted to touch upon the mechanisms of actions of diarrhea and things that you already talked about, the inflammatory, osmotic, secretory dysmotility. And I stress on this because I think it's a very useful way to frame your thinking when a patient comes to you with diarrhea. So when we take inflammatory causes of diarrhea, the fundamental mechanism is that you have mucosal disruption resulting in the spilling of the serum into the intestinal lumen. And like we mentioned before, conditions that can cause this kind of disruption can either be infectious or non-infectious. And as we already spoken of, the infectious can be bacterial, virus, parasites. We're not going to go through the details of that, but just to keep that in mind. And then the non-infectious causes of that can be IBD, IBS, and cancers, colorectal cancers, for example. So the historical features that we ask about is that we ask for symptoms of abdominal pain, fever, tenesmus, bloody or mucoid stools, and these are things that are usually suggestive of an underlying inflammatory condition, which you guys have asked a lot about. The second category of osmotic diarrhea, here the fundamental mechanism is that you have an accumulation of osmotically active particles that results from indigestion of non-absorbable substances or maldigestion or malabsorption in general. And this creates an osmotic gradient in the gut that favors movement of fluid into the lumen, and that results in diarrhea. And on history, you need to ask for symptoms of weight loss, Steatorrhea, I don't think this was asked in this history, but it's fine. It's not something that seemed to have added much to the case, but those are usually clues of maldigestion. More specifically, the volume of the diarrhea in osmotic diarrhea is directly proportionate to the periods of food intake, meaning this type of diarrhea increases with food and decreases during fasting or at night. And that is a very specific historical feature that you can rule out osmotic or from other kinds of diarrheas. And conditions that can cause osmotic diarrhea include lactulose intolerance, laxative use, ingestions of sugary alcohols in soft drinks or candies, celiac disease, and pancreatic insufficiency. And each one of these were already talked about rightly by the both of you in taking more history in the HPI. The third one is secretory diarrhea, and this is a diarrhea that results from secretion of excessive isotonic fluids into the intestines. So the questions you'd be asking for secretory diarrhea is whether or not the diarrhea is watery, which is typical of secretory diarrhea, and how much volume of it is, because this type of diarrhea is very large in amount and does not change during periods of fasting. So on history, this patient will tell you, even though I'm asleep at night, he still has diarrhea ongoing during the night. And the conditions that you think about with secretory diarrhea are neuroendocrine tumors like gastrinomas, gluconomas, or VIPomas even. And the last category is dysmotility, which can either be a hypermotility or a hypomotility. Hypermotility causes decreased transit of the intestinal content, so that prevents the fluid from reabsorbing into the small intestine and overwhelming the absorption capacity of the large intestines. So that's why you get diarrhea in that case. And hypomotility is associated with development of small bacterial growth. So on history, the diarrhea in dysmotility is usually a small volume, high frequency. Steatorrhea is commonly seen as well. And dysmotility in general is often a symptom of a systematic disease. So they don't really just present with diarrhea. Systemic diseases such as diabetes, thyrotoxicosis, scleroderma, IBS can also have this kind of diarrhea alongside it. So you would ask for symptoms of those specific diseases as well. Okay, so that's just on the classifications that you need to think about when you have a patient with diarrhea. Next, we'll talk a little bit about C. diff infections. And the reason why I brought a case of C. diff for today's case as diarrhea, because C. diff is a fairly common infection that we see in the inpatient service for us in internal medicine. Maybe not so much in the outpatient, but we have patients being admitted for other things, receive antibiotics for a long time, and subsequently have C. diff as a complication of their stay, usually. So the main risk factors in C. diff infections is antibiotic use. Definitely. That is the number one trigger that would make you think of a C. diff infection. So any antibiotic use within the last 3 months associates with C. diff infections. It's usually any kind of antibiotic, but specifically they do mention third or fourth generation cephalosporins, fluoroquinolones, carbapenems, and clindamycin. But you should keep your thinking always primed on antibiotic use and diarrhea, equaling C. diff infections always. So that is the number one risk factor that you should think about. Pathogenesis of it is usually fecal oral, usually in a colonized host as well. Most infections require both acquisition of a C. diff plus loss of gut micro abundance or diversity, meaning they're taking antibiotics that's decreasing the bacteria in their gut. Subsequently, they're also getting C. diff infection. And the symptoms are usually toxin mediated, which is why when we are thinking of C. diff, we send for a Clostridium difficile toxin A and B, because those are the two toxins that are being produced and that cause the symptoms. The features of it is loose, watery diarrhea, fever, abdominal pain, isolated white blood cells. And what are the complications that we think about in C. diff infections, if you know, Khalid, Mariam?
Pseudomembranous colitis? Or is that the disease itself? It's not a complication.
That is the disease itself, but what is the complication of that? What's the thing that we're afraid of in C. diff?
It's toxic megacolon.
Yes, correct. Yeah. So toxic megacolon is something that we think about, and subsequent perforation of the colon as well. The colitis can become a fulminant colitis, affecting a lot of the gut, and that causes a 65% mortality. So those are the things that we keep mind of when we have patients with C. diff infections. So what are the ways to diagnose C. diff infections? Do you guys know of any other lab tests that we can do other than the toxins that we talked about in this patient?
The new test, I think the nucleic acid assay, something like that. I heard about it.
Yeah, PCR toxin gene. So there are three main tests that we can do for C. diff infections. There is a C. diff antigen that you can check, and this is a test that is produced by all of the C. diff strains, toxigenic or non-toxigenic. So it doesn't really tell us whether or not this is the toxins causing the C. diff. It only tells us that there is C. diff. So it's not very helpful in that sense. What you also need is a toxin A and B, which is more specific to toxin-producing strains and tells us that there is toxins in the body. And the test that Khalid mentioned, which is the PCR toxin gene, and this only tells us that the C. diff strain that you're testing may have the toxin gene, but it doesn't necessarily produce the toxin. So this can be positive even in the absence of active infection. So among all these three tests, the most useful one to have is usually the toxin A and B tests. I don't know if Dr. Ali would like to add something.
That's true. So what we do basically is the toxin A and B, and if you go and look for their positive predictive value or specificity, it's around 70. I'm not sure for A or B, but the other one probably a little bit higher, 80 or more. Now, as you said, for the antigen test or the nucleic acid, if it can be positive even if there is no diarrhea, even if there is no disease. So we don't use it. I don't know honestly how people using that, probably with infectious disease. I don't know if they combine the two tests or there is a specific entity where they test for the antigen. But what we do is the toxins basically.
Okay.
Of course, Sarah, so the other clinical like entity you will notice when you start your clinical work, if you suspect C. diff and you wanted to send a stool sample, for example, to test the toxins, they would only accept the watery sample, like watery diarrhea. So again, it's choosing the test is one thing, but also choosing the sample is the other thing. So patient can have diarrhea, which is the consistency is not watery. They don't usually process that one. So if you wanted to send for toxins A and B, it should be really watery sample.
Okay, thank you for that, Doctor. So the next part of C. diff infections is categorizing what kind of C. diff it is. So there are three main categories for C. diff infection: severe, non-severe, severe, and fulminant. Do any of you know the difference between these three categories? Khalid, Mariam?
What I know is that severe consists of, for example, hypotension and like toxic megacolon. But I'm not sure what differentiates fulminant from severe.
So you actually have it right for fulminant. Fulminant is the one that has hypotension, has shock, has megacolon. That's the fulminant one. Severe is when you have a white blood cell count of more than 15 or creatinine above 1.5. And non-severe is basically you have the clinical picture, but white blood cell count of less than 15 and the creatinine count that's less than 1.5. Okay. And do you know what is the treatment for each of these categories?
Okay, Khalid, do you want to talk? Okay.
No, go ahead, William.
Okay, so usually for the non-severe, you would go for vancomycin.
Okay. Perfect.
And yes, and then if that did not work, you would also add like fidaxomicin. And in cases of refractory, there's the fecal transplant. In cases of fulminant, you would go straight forward to, for example, metronidazole, like IV metronidazole.
Okay. I'm glad you
Plus
added
minus vancomycin.
Yeah.
Dr.
Yeah, exactly.
Sarah,
That's exactly, yes.
if I could just ask you a question, because I didn't get that part. I read that metronidazole is so slowly being weaned away, and that it's not really useful, and that they only use it in very severe cases as like a, you know what, if vancomycin is not working, let's just try. Is that true, or can you clarify that, please?
That is true. Metronidazole used to be one of the first line drugs that you use with vancomycin, even in the non-severe cases. But they're not trying to stop that. They are stopping that because there has been increased resistance with metronidazole noted. So it's only used now in fulminant cases with vancomycin when a patient comes in with hypotension and shock, as you said, as a last ditch effort. So yes, you're correct. It's not used as a first line anymore, but vancomycin remains the first line treatment for C. diff infection. I don't know if Dr. Ali would like to add anything to that as well.
Nothing to add. You are right. So we use vancomycin as first line treatment, and you just remember this is oral vancomycin. So the IV vancomycin doesn't work because it's not secreted to the bowel, to the intestine. So you give oral vancomycin. It's the first line. It works nicely. And as Mariam mentioned, you could definitely treat with fidaxomicin, but you know it's expensive and it's not first line. So if the case is severe, I would go and use fidaxomicin. I got 2 cases last week. So there was a lady who's known C. diff infection, and she been treated with vancomycin, and she's on long-term tapering down vancomycin therapy, and she's doing well, though her initial colitis was severe. The other one is a newly diagnosed, almost similar to your case, but was a dental procedure for some reason, which is not very clear. They kept her for 8 days on antibiotics. She's coming with bad diarrhea, and finally she got C. diff. So again, we used oral vancomycin, and she is improving.
Thank you, doctor. So usually the duration of treatment in C. diff is 10 days for non-fulminant infections. If you have a patient who is on the floor and still requires to need the antibiotics that probably caused the C. diff, then they can still continue their antibiotics plus 7 or 14 days of the vancomycin should be done. And just the last point, I wasn't going to talk about this, but since Mariam had brought it up, in cases of reoccurrence, what do you do? So reoccurrence usually does happen in around 25% of patients after the first episode within 30 days. So in a first episode recurrence, you take a tapered and pulse vancomycin regimen for, I can't remember how many weeks, but it's, I think, a 2 or 3 month therapy. And then if it still recurs a second time, you do again the same vancomycin regimen. But at the third occurrence, if the vancomycin wasn't effective the first 2 times, then you can be evaluated for a fecal transplant. Although I don't really know how much they actually do that, but that's the guideline for reoccurrence of C. diff. Okay. Any other questions about the case, about C. diff, about diarrhea in general?
It was very helpful, doctor. Thank you. Doctors.
Thank you all for this informative discussion. We will open the floor to the audience now to share their questions and comments.
No questions?
Yeah, it seems that we don't have any more questions from the audience side. It was very comprehensive and insightful. So we would like to conclude today's session. Thank you, Dr. Ali, Dr. Sarah, Khalid, and Mariam for this comprehensive discussion. It was very enlightening. And I would also like to thank the audience for attending today's episode. We hope we meet you all again next week, inshallah. Thank you.
I would like to say thank you for Sarah. It's really impressive presentation, well organized, and it's almost perfect, honestly. Thank you for that good preparation, Sarah. Thank you for Khalid and Mariam also. Wish you all the best.
Thank you.
Thank you for our discussants as well. Very well done in presenting and thinking through the case with us. Well done.
Thank you for your time, guys, and for your efforts. And thank you, doctors.
Lunchtime.